Good day, I am Dr.K Gireesh, physician, neurophysician and neurosurgeon. This is the RNA series 29. RNA series is nothing but random questions in neurology and neurosurgery with answers by Dr. K Gireesh. That's myself. This is to benefit the practitioners of neuroscience and the medical field for a lifelong learning, and also for public awareness through mass communication. The question that I am addressing in this particular series is, what are the causes of raised intracranial pressure or increased intracranial pressure? Increased intracranial pressure is a serious final common pathway of a variety of neurological injuries. It is characterized by increased volume of the intracranial vault and is a major challenge in the intensive care units. Elevated intracranial pressure has consistently been associated with a very poor outcome. One of the commonest pathological phenomena encountered by the neurosurgeon is that the increased intracranial pressure, and it's quite often, and it has a profound influence on the outcome of many intracranial problems. That is, increased intracranial pressure has profound influence on the outcome of many intracranial neurological and neurosurgical problems. In a review of the studies by Tregear et al., there is a role of intracranial pressure values and patterns in predicting the outcome of traumatic brain injury. A lovely study and published in the Neurocritical Care of 2007. In that review, it has been found, especially after traumatic brain injury, the rate of death was 18.4% for patients with an intracranial pressure of less than 20 mm of mercury, but it rose up to 55.6% for those with an increased intracranial pressure of more than 40 mm mercury. That's a study which shows that increased intracranial pressure following traumatic brain injury has to be treated well. According to the Monroe-Kelly doctrine, the cranial vault is a fixed space about 1400 to 1700 ml in an average sized adult. It has got three compartments: blood, which is around 10%, 150 ml, CSF, which is another 10%, 150 ml, and the brain tissue, which is 80%, almost 1400 ml. So these are the three compartments, and that has been described by Monroe-Kelly doctrine. Now, Monroe is Dr. Alexander Monroe. He is a Scottish physician and anatomist, and Dr. George Kelly, Scottish surgeon. So according to the Monroe-Kelly doctrine, the cranial vault is a fixed space of about 1400 to 1700 ml in an average sized adult. It contains three compartments: blood 10%, 150 ml, cerebrospinal fluid 10%, another 150 ml, and the brain tissue 80%, 1400 ml. If one expands, the other has to give way. If that doesn't happen, the intracranial pressure rises. CSF is produced by, or cerebrospinal fluid is produced by the choroid plexus in the ventricles and elsewhere in the CNS at a rate of 20 ml per hour. That means 500 ml per day. And this drains into the venous system via the arachnoid villi and granulations. The normal intracranial pressure ranges from 50 to 200 mm of water or 3 to 15 mm mercury. In routine intensive care unit practice, the goal of IZP or raised intracranial pressure management is to maintain the levels below 20 mm mercury. Just beyond 20, even 20 to 25, it's a kiss of death. So, this has been reported in the Journal of Neurotrauma by Breton et al. In the year 2007. So, in order to maintain a constant IZP, any increase in volume of an intracranial element must be equally compensated by a decrease in the volume of another component, otherwise the IZP will rise. This is exactly the Monro-Kelly doctrine. The pressure-volume relationship between IZP, the volume of CSF, blood, and the brain tissue and cerebral perfusion pressure is known as the Monro-Kelly doctrine or the Monro-Kelly hypothesis. As IZP reaches 50 to 60 mm mercury, it approaches arterial pressure in the vessels of the circle of Willis and brings about a global ischemia, as pointed out by Royapettah et al. Well, the causes of intracranial pressure can be an intracranial mass lesion or an increase in brain volume or an increase in CSF volume. Intracranial mass lesions can be hemorrhage, can be a brain tumor, can be cerebral abscess. Increased brain volume, that is cytotoxic edema or osmotic edema, like ischemic stroke, global hypoxia, Ray's syndrome, acute hyponatremia, hepatic encephalopathy, idiopathic pseudotumor cerebri, toxins and medications, lead, tetracycline, doxycycline, rofecoxib, retinoic acid. Now, it can be intracranial mass lesion, increased brain volume, or increased CSF volume. Increased CSF volume causes are hydrocephalus, communicating, non-communicating, choroid plexus papilloma, decreased CSF absorption, that is venous sinus thrombosis, CSF outflow obstruction. So, these are also mass lesion, brain volume, or increase in the CSF volume. The more common representative conditions, of each one of these, each compartments I can tell, raised IZP resulting from increased blood volume, like the venous congestion, cerebral venous thrombosis, drugs causing dilatation of cerebral vessels. The raised intracranial pressure from increased brain volume. It can be even a space-occupying lesion, a tumor, AVM, intraparenchymal clots, abscess, cerebral edema from metabolic electrolyte as well as infective causes. Raised IZP from increased CSF. It will be hydrocephalus, obstructive, communicating, increased CSF production or decreased CSF absorption, any one of these like the meningitis or tumors. So, all these are the commonest causes of the raised intracranial pressure. So, that's in brief on what are the causes of a raised intracranial pressure. Thank you very much.